KNIV check.
I heard a good thing about it.
So good. Okay, what is it?
It's got Daniel Craig in it. It's the main. It's kind of like Clue, like the game Clue.
Oh, all right.
So good.
Hi, everyone. Good afternoon. Thank you for participating in the Neonatal NAS Initiative webinar. My name is Laura Lane. I'm the Women's Health Deputy Director at the Department of Public Health, and I'll be hosting today's webinar with Katie Kopp. So just a quick overview for today. We are happy to have Dr. Piccirillo, who is Assistant Professor of Pediatrics at Tufts University School of Medicine. He'll present about Eat, Sleep, and Console. And Dr. Patel will also share a template for how to formalize and structure your QI project. So we will begin with a few housekeeping reminders. Your lines are all muted right now to reduce the background noise. So if you would like to comment or ask questions, press *6. You can also use the chat box, which we will be monitoring throughout the webinar. And we really want this to be engaging and participatory, so please use the chat box, and then when we open the line for discussion, please share your successes and challenges so we can all learn from each other. So thank you in advance for your attention and participation. Just to take a look at the key driver diagram before we get started, it has not changed, but it's here for reference. The Vaughn micro lesson to watch for this month is number 12. And at this time, I'd like to introduce our guest speaker, Dr. Piccirillo. As I mentioned, Dr. Piccirillo is Assistant Professor of Pediatrics at Tufts University School of Medicine. In addition to his clinical work as a neonatologist at the Barbara Bush Children's Hospital Level 4 NICU, Dr. Piccirillo is involved in the creation, implementation, and data analysis of quality improvement efforts in newborn medicine. He is also a member of the neonatal leadership structure for the Northern New England Perinatal Quality Improvement Network and Maine Perinatal Collaborative. His areas of interest include implementation of lean methodology for quality improvement projects and the introduction of quality improvement measures to clinicians in perinatal quality collaboratives. In addition, he is neonatal faculty for Vermont Oxford Network and has been involved in advocacy at the state and national levels for NAS infants. So welcome, Dr. Piccirillo. I'll turn it over to you at this time. It's *6 to unmute.
Great, Laura. Thank you very much, and good afternoon, everyone, and greetings from slightly cold and snowing Portland, Maine. I just want to very quickly thank Ravi and everyone for the invite today to give the talk and to really be able to engage with folks from other states. All right, next slide. All right, I have no specific disclosures. However, I will be discussing off-label use of morphine and other medications for treatment of NAS. Next slide. I also disclose I will try not to have any slides of Super Bowl 51 for everyone in the crowd. All right, next slide. Well, that's not totally true, but just if you ask any Patriot fan other than Mark Wahlberg, people actually did stop watching that Super Bowl at halftime. On the left is actually the early version of the newspaper that was published in Florida showing Robert Alford returning Tom Brady's interception for a touchdown. Clearly not quite as famous as the Dewey defeats Truman headline from post-World War II. Next slide. All right, so what is Maine like? So this was actually a part of a talk I gave a year ago. This was actually Caribou, Maine, which is the northern tip of Maine. Next slide. And I just want to show you, this was 147 inches of snow, and that was actually not quite at the end of February. Now, it typically snows in Caribou right up through April. So it's clearly a different style of living here in the Northeast. Next slide. When I was putting together this talk over the weekend, I did want to look at the differences between where I live in Cape Elizabeth, Maine, and Atlanta. So clearly, I want to be spending time in Atlanta the next couple of weeks rather than Cape Elizabeth. Next slide. So not surprisingly, and everyone should be pretty familiar with this slide, this is Stephen Patrick's really seminal article in JAMA from 2012, really putting newborn neonatal abstinence syndrome at the front and center for folks. I think we all realize there was an issue with NAS, but I don't think we could ever wrap our arms around it. And Stephen's article really started putting some numbers to this. Again, people are pretty familiar with a tripling of NAS rates in U.S. hospitals during the decade of the 2000s from about 1.2 to about 3.6. Next slide. So the CDC started looking at this too, and they published an article in the MMWR and looking at rates of NAS. Next slide. Clearly, there's a few things that stand out on this map for me. One, some states, specifically like Maine, had incredibly high rates, and New England had very high rates. But it also became very clear that there was very little data around the country, as either states didn't think there was much of an issue, or there wasn't an issue with neonatal abstinence syndrome across the country, or the public health agencies in the states just didn't track it. I do want to point out Maine, Vermont, and West Virginia here at the time all had rates greater than 30 per 1,000, or 3% of their deliveries, and I'll get more into the specific data in a moment. Next slide. So right about this time, the folks at Dartmouth had really published a pretty unique article looking at focusing on non-pharmacologic care. Up to this point, a lot of single centers, a lot of state collaboratives such as Ohio, and the Vaughan Collaborative Network started looking at the babies who are pharmacologically treated and can we do a better job streamlining their care. Some great work was done, especially with the Vermont-Oxford Network in the U.S. collaborative with that, and they showed a decrease of about 10 to 20% in length of stay for pharmacologically treated babies. I think the folks at Dartmouth really hit the nail on the head, and they said, you know, what about non-pharmacologic care? Is there something specific we can do? This is really driven by the pediatric hospitalists, and they looked at, you know, did these babies really need to be in a NICU who had neonatal abstinence syndrome? So made the move and started admitting the infants to the pediatric unit, where mom and baby or mom, dad, and baby can actually share a private room together and do all the non-pharmacologic things that you need to do: low stimulation, low light, supportive environment, breastfeeding, rooming in. And what they found was prior to the onset of admitting the infants to the pediatric unit and really using constant rooming in, they were pharmacologically treating about half their babies. With this new model of care, they were able to decrease that down to about a quarter, also reducing the length of stay for the pharmacologically treated infants, as you can see, by about 4.5 days. Saw no difference in readmission rates, and they obviously saw a decrease in cost, which is not surprising. Next slide. And then again, this is their control chart looking at the decrease in cost over time from the, as you can see, the annotations on there, reducing the cost from close to $20,000 per patient per stay down to a little bit less than $9,000 per patient per stay. Next slide. I'm going to skip the slide and go one more slide, please. So right around the same time, Yale, as Dartmouth had published, the folks at Yale had also published really kind of the groundbreaking paper, which now is everyone refers to it as the Eat, Sleep, Console paper. So Mac Grossman and colleagues at Yale really took non-pharmacologic care to the next level. Again, they developed a few things on their QI project. They, again, took the babies out of the very large newborn intensive care unit and placed them in a low stimulation environment. But really, it was a message of empowerment for the families, and it was a message for how to continuously care for the babies. How can moms be medication and dads be medication by doing skin to skin, by providing breast milk when appropriate, and having a low light and a low stimulation environment. And the thing I really liked about this, the messaging was non-pharmacologic care is treatment in itself. And that's something, if you listen to the authors from Yale speak, you'll hear that time and time again, that non-pharmacologic care is treatment. And I really love that message. A big piece of this was also doing prenatal counseling, so meeting with the families ahead of time and talking about expectations. Again, a huge empowerment message to family. And the last piece is really what all of us focus on is the assessment, which came to be known as Eat, Sleep, Console. Next slide. So as you can see here on the control chart from Yale, if you were an infant who was exposed to opiates in New Haven, Connecticut in the end of 2008 through 2010, about close to 100% of the time, you were treated pharmacologically for your withdrawal. All those babies went to the NICU, they all got treated. As time went down, you can see the first step was they started transferring the babies to the inpatient pediatric unit, and it reduced the percent pharmacologic treatment rate from close to 100 down to about 80%. And then with more initiations, including rapid morphine weans, prenatal counseling, and then starting to use PRN dosing of morphine, you saw the mean percent treated babies went all the way down to about 28% by 2014, 2015. So this, again, really took a lot of people by storm and said, wow, maybe there's a different way to do this. And maybe we need to open our minds up a little bit and say, boy, let's look at this a little bit closer. Next slide. One of the things I liked about the group at Yale and their publications, where they actually looked at lining Finnegan scoring up against Eat, Sleep, Console on the same infants. So they took 50 infants who were scored with a Finnegan, but they were actually managed with Eat, Sleep, Console. So what they found was, if you specifically stayed on the scoring piece for Finnegan and you treated based upon the typical Finnegan scoring rules, which again, they were all different thresholds, but they used 3 scores of 8 in a row or 2 scores of 12 or above. So if for those 50 infants, if they use that scoring system, as you can see, 60% of the babies would have been treated pharmacologically. But if the babies were managed just with Eat, Sleep, Console, 12% of the babies were treated pharmacologically. So that was, again, a really huge step where people started being able to compare in the same population, the Finnegan versus Eat, Sleep, Console for assessment. Next slide. So the pieces for Eat, Sleep, Console, again, this distills it down a lot, and it's a little bit more complex, but one is the care is really focused around the non-pharmacologic interventions. It is a true partnership with the families. The way I look at it is, maybe we're not going to be pharmacologically treating mild withdrawal cases. If you talk to your staff, it's very less laborious documentation, and we'll get into that in a few slides. In the last piece, and I hear this time and time again from families, it's really easy to understand. So we've had several families over the past 2 years who've had children that have been born at our hospital who were managed through the Finnegan scoring system and our old standard system, and more recently managed with Eat, Sleep, Console. And the feedback has been really impressive, and I think the one thing I hear a lot is the families say it's easy to understand. Everyone can understand if a baby's eating, if a baby's sleeping, or if a baby's consolable. What's hard is, and we'll get into the Finnegan scoring system, and I still have difficulty, is to understand what is a loose stool versus a watery stool, for example. So this slide really shows side by side the ESC Care tool on the left and the Finnegan scoring system on the right. Again, I apologize, this is small, but the next slide will start to zoom in a little bit. I can advance my slide, please. So Eat Sleep Console, as you can see, the top half really looks like, at the key measures, is the baby eating? And is the eating due to NAS, yes or no? Is the baby sleeping? And sleeping for less than 1 hour due to NAS, yes or no? And is the baby consolable? So inability to console within 10 minutes due to NAS, yes or no? The rest of the sheet really looks at what type of approaches have people using for non-pharmacologic care for, again, both the caregivers and the parents for the baby. And then specifically at the bottom of the sheet looks at the non-pharmacologic interventions. Next slide. So again, this enhances that Eat Sleep Console care tool a little bit larger. So if you look at the Finnegan scoring system itself, 21 items, I mean, clearly lots of subjectivity within the 21 items themselves. Next slide. Again, I've always had, if there's one objective measure on here, which is temperature, the rest are very subjective. And again, I would really point out to, if you had 2 or 3 people in the room, would they score the baby the exact same for a hyperactive molar reflex versus a markedly hyperactive molar reflex? Or exactly what is excessive sucking? Regurgitation and projectile vomiting, having had a couple kids, it's all the same to me, and the same thing between loose and watery stools. So you can imagine there's an immense amount of overlap on this. Rachel Osborne, who's one of the authors of the original Eat Sleep Console paper, I was at a conference with her about 6 months ago in Michigan. And Rachel told a great story, and I apologize for ripping off her story a little bit, but Rachel tells a story of a baby who was in their nursery and who had 2 scores of 8 and had a current score of 7. And this baby had sneezed twice. And what Rachel's point of the story was, if this baby sneezed once more in the next assessment period, which was still an hour and a half long, that one extra sneeze would have given the baby a score of 8, and now this baby would have been started on pharmacologic treatment at her hospital. So pharmacologic treatment, as most people know, basically places the baby in the hospital for up to somewhere on average between 18 and 20 days. And if that baby didn't sneeze, that baby would have had a score of 7 and not necessarily been started on pharmacologic treatment. And if the scores went down after that, maybe the baby only stays 5 days in the facility. So the point of the Finnegan scoring system in this example was one sneeze with a determination of 2 weeks in the hospital on average. So that really resonated me when she told the story. Next slide. And one more slide. So if you look at the Finnegan versus Eat Sleep Console, and I will say from the beginning, I'm not a strict constructionalist about Eat Sleep Console. A couple things I probably should have said this at the beginning. I do believe that there are some babies who absolutely, unequivocally need pharmacologic treatment for their withdrawal. Whether it's severe withdrawal, whether it's polypharmacy, whether the baby has a genetic polymorphism that makes them more apt to suffer worse withdrawal. But there are absolutely some babies who need pharmacologic treatment. So if you're in a facility and there is a baby that needs to be treated, it's not a failure. So I just always want to remind that recently we had a run of, I believe, 6 or 7 months where we did not pharmacologically treat any of our infant babies, and one baby needed to be treated, and one of our pediatric hospitalists was really, really disappointed. And I remember hearing this and told him, no, it's okay. If the baby needs pharmacologic treatment, the baby needs pharmacologic treatment. But we'll talk about how we did the pharmacologic treatment later. So if you look at, again, lining up Finnegan versus Eat Sleep Console, thanks. Again, 21 items in a Finnegan, 3 items in Eat Sleep Console care tool. Again, totally subjective. Finnegan, even though it's been around since the early 1970s, it's never been validated. Clearly, Eat Sleep Console has never been validated. Again, with subjective scoring, there's certainly integrated reliability issues on both sides. We know with the Finnegan scoring system, there's definitely high rates of pharmacologic treatment. Eat Sleep Console, rooming is the key to the model without a doubt. And then lastly, are there some long-term outcome issues with prolonged medication exposure, specifically morphine and methadone? And there definitely are some concerns. And then on the other side, which I can't tell you it's totally safe having untreated withdrawal. is that safe in a baby, and does that have deleterious effects to neurological development? And I'm not sure. Next slide. All right, so if we go to Mark Hudak's AAP statement from 2012, again, I just want to point out the piece in the red that no studies to date have compared the use of different withdrawal score thresholds for initiating pharmacologic intervention on short-term outcomes. So that's something really important. And then the threshold for starting medication, it's artificial. Is it 3/8? Is it 2/12? Is it 3/9? As you can see, there's definitely different thresholds by nursery. There's not standard criteria. And we looked at this in Massachusetts across the 48 delivery hospitals. We found vastly different thresholds for initiation of pharmacologic therapy. And the last piece, this is from Mark Brown at Eastern Maine Medical Center in Bangor, that Mark always got mad at me whenever I said the infant requires pharmacologic treatment. Mark would tell you that the provider decided to start pharmacologic treatment. So I always want to remember, keep that in the back of my mind. Next slide. All right, so is morphine safe? So there are different studies you can find, both if you look at a Terrian study looking at the cellular structure and apoptosis for morphine exposure in human microglial cells. You can look at Steinhorn's collaborative in Australia, showing that morphine-exposed children were more likely to show behavioral dysregulation than children who were not morphine-exposed. But again, at 7 years of age, those differences tended to wash out. But even more recently, last year, looking at babies with NAS as statistically smaller head circumferences than control themselves. So clearly, there is an effect on morphine on the neonates, but it's very hard to parse that away from the in utero environment from these babies, without a doubt. Next slide. So if the question is morphine safe or not, is methadone safer? And so again, there's been a couple studies specifically looking at this. Monley study looked at diffusion MRI in showing that prenatal methadone exposure showed some microstructural alteration in the white matter tracts in infants that were exposed to methadone versus infants that were not exposed to methadone. And then also looking at babies who were exposed to methadone, that the babies who were exposed to methadone have lower scores in cognitive composite and total motor composite scores on the Bayley 3 exams. So next slide. So I guess at the end of the day, I don't know if untreated withdrawal is any safer. There's no studies on this at all. So this kind of leaves us in a bit of a quandary as to what is the best way to care for these infants. Is it medication? Is it not medication? And I think we're starting to focus more on long-term developmental outcomes. Hopefully that will become very clear in the next 5 to 10 years. Next slide. All right, so what about rooming in? So is it just rooming in? So if you take a baby out of a newborn intensive care unit or a special care nursery, and you place the baby in a single private room with the family, will that have the greatest impact at all? And so we looked at this. This is Maine Medical Center data from 2016 to 2018, where our babies had always roomed in. The babies were continuously roomed in a step-down nursery, so the minute moms were discharged from the hospital, they came down to the step-down nursery, single private room, and they stayed in. Over the left-hand side of the graph, over a 2.5-year, two-year time period, our percent treated pharmacologically was about, you can see, about 35 to 40%, and it didn't change over 24 months. Once Eat Sleep Console was rolled out off to the right-hand side, we saw a huge decrease almost immediately in the percent that were treated pharmacologically. Now, these were substance-exposed newborns greater than or equal to 35 weeks who were inborn at our facility. Next slide. But does Eat Sleep Console work everywhere? And again, like most QI projects, and I know Ravi will be talking to people about this, one of the big pushes, and I always really make sure I share this with our colleagues, is that just because it's a change, it doesn't necessarily mean it's going to make a difference. It may make things better, it may make things worse, or it may be the exact same. Next slide. This is from Alicia Walkman's article published in Journal of Perinatology 2 years ago now, where, again, Boston University Medical Center is really on the forefront of NAS treatment and treatment of mothers with substance use disorder. I have a long history, and really just a lot of great work comes out of Boston University and Alicia's group. As you can see here, their control chart looking at length of stay. On the left-hand side, the mean length of stay for all the opioid-exposed newborns, as you can see, was about 2.5 weeks. You can see all the annotations of non-farm care bundle staff QI education. When they switched to methadone is when they started to decrease down to approximately 10-day length of stay. But as you can see where I circled, when they implemented Eat Sleep Console tool and hospital-based cuddlers, it didn't make a difference at all. The length of stay was unchanged for the next year. Next slide. All right, so what do we do at Maine Medical Center? So Maine Medical Center is a level 4 NICU located in Portland, Maine. It services the bottom half of Maine, which is about, and there's only 11,500 deliveries in the entire state of Maine, and we cover about 2/3 of the delivery. Most of the population lives in southern Maine and on the coastal side of Maine. So we launched a clinical initiative in September 2018 to really improve the care of infants and families affected by neonatal abstinence syndrome. It was a multidisciplinary project, so we had really just an incredible response when we send out a call for help within the hospital as to who wanted to work on this project. We had so many people, we had to break them into several different groups at our facility. There was one group that really concentrated on prenatal, really about consultation and education to the families. One was about implementation of Eat Sleep Console itself, and then the third work group worked on pharmacology. So the main aim of the project was to decrease the percent of pharmacologically treated substance-exposed newborns by 20%. So our baseline was about 35%. With implementation of the Eat Sleep Console care tool. And then again, we had multiple PDSA cycles, but our big push really was on education. And that was some very good advice we got from our colleagues at Dartmouth. Next slide. So really, the main 5 PDSAs you can see here started in September of 2017, and we look towards a launch in April of 2018. Again, establishing a task force, making sure we collected our baseline data. Our second PDSA cycle was actually sending 2 teams out for Eat Sleep Console team training. Now, this was offered at Dartmouth. It's a simulation-based Eat Sleep Console team training. We were very fortunate, again, to be close to Dartmouth. We can drive over there. And being able to send 2 teams out there was really important. Multidisciplinary teams consisting of physicians, nurses, and nursing educators. So third PDSA cycle was development of patient materials and EMR documentation. And the funniest piece of, I guess, as I sit back and look at all the things we did, the electronic medical record documentation actually was the easiest part of this. I thought it was going to be the most stressful and the issue that was going to really keep us back from implementation, but it turned out our partners in information systems really were ahead of the curve on this, and they built this very quickly. The fourth PDSA was probably the heaviest lift, was the staff training itself, having to train 240 staff members. So all physicians, nurses, nursing aides received training in Eat Sleep Console. And then the fifth piece was development of our PRN medication guidelines. Next slide. So just really quick point on data collection. I'm totally a data nerd. So this was really important to us, and so very luckily we had a good relationship with the Northern New England Perinatal Quality Improvement Network, and this was our data collection sheet. It's about 30 items specifically looking at all different factors of exposures, a lot about mom, a lot about demographic information on babies. Next slide. And also a lot of outcomes on the babies. Were the babies transferred? Were the babies discharged? What type of medication they were on? How long were they on for the duration of pharmacologic treatment? Who did they get discharged to? Were they discharged to parents? Were they discharged into the foster care system? So it allowed us to really kind of get our arms around the problem, not just at our hospital in Maine, but also across all of northern New England. And I'll come back to some of the northern New England slides in a little while. Next slide. All right, so simulation-based training. Again, I can't begin to really stress how important this piece was itself. Having standardized Eat Sleep Console cases at Dartmouth with a provider, a parent, and an actual infant. More often than not, they were mannequins, but sometimes some of the nursing staff that were acting as the parents would bring their own babies in, which really made it real if the baby was started crying in front of us during the standardized cases. These interactions were filmed, and then they were reviewed with a debriefing, much like we do, obviously, with training newborn resuscitation, for example. Next slide. Patient materials, and then you can go to the next slide too. So these are materials that we gave to the families, both prenatally and then once they came to the hospital, really talking about the signs and symptoms of neonatal abstinence syndrome, really introducing Eat, Sleep, Console, and also frequently asked questions on there. For example, can they breastfeed their baby? So again, this was done in partnership with our Parent and Family Advisory Council and focus groups from women with substance use disorder. Next slide. All right, staff training. So again, for me, this was always the heavy lift. So the question was who to train. So clearly it was any nurse who cared for a baby anywhere in our hospital, which could be well infant nursery, mother baby unit, special care unit, NICU, pediatrics, anywhere a baby was cared for. And also the providers. We made sure we included all of our pediatricians, our NNPs, physician assistants, family practitioners, residents, and then anyone else. So our cuddlers, so the people volunteer cuddlers actually had a very truncated Eat, Sleep, Console education. Our dietitians, our physical and occupational therapists. So how people a lot of times ask how long to train. It really depends upon how it gets set up, but our training sessions were about 1 hour long. And then the greater question is about sustainability and how often do we train. And so we struggled a little bit with this. Clearly, all the new hires get education on Eat, Sleep, Console, but we haven't really done a good job at looking at annual competencies for Eat, Sleep, Console, and that's something, again, we're going to continue to work on. Next slide. PRN medication. So we developed some PRN medication guidelines. Really, there's not a lot of evidence. This was really looking at best practice that we were able to glean from other institutions that had just started PRN dosing, and really it was in some ways a negotiation with the pediatricians, the neonatologists, and our pediatric pharmacists in our hospital. So we met frequently with pharmacy to really determine a standard dosage and potential frequency. We need to decide about where should the location of doses be. Can they be in the well infant nursery or can they be in the special care nursery? We decided, again, and this was what made sense for our hospital, to give the first dose in the well infant nursery. So if the baby was only treated with one dose pharmacologically, they could remain in the well infant nursery with their family. If they required a second dose, they would have to get transferred to the special care nursery. The third big issue is, do we monitor or not monitor? Again, a lot of debate around should the babies be on cardiorespiratory monitors if they're getting pharmacologically treated? Should they be on pulse oximetry? When we looked in Massachusetts, when I was there several years ago, we did a survey of the hospitals, and it was almost split down the middle. Half the hospitals routinely monitored either with cardiorespiratory monitors or pulse oximetry when the babies would be pharmacologically treated, and half the hospitals did not monitor at all. So one of the big questions I get, especially from our community hospitals, is it safe to give a dose to a baby in a community hospital, whether they're monitored or not monitored? And I always want to remind people that these babies are not morphine naive. They have been exposed to opiates almost the entire gestation. So giving one dose of morphine, and certainly at a lower dose, will not make the baby apneic. Again, these babies have seen morphine for a long time. And clearly we developed the dosing protocol, which is on the next couple of slides. All right, next slide. Again, it's a pharmacologic management algorithm. People are welcome to borrow this, steal this, share it. This is what worked for us. Next slide, zone in a little bit closer. So again, if the care team determines that an infant meets the threshold for needing pharmacologic treatment, that we basically gave the baby one dose of 0.05 milligrams per kilo per dose orally of morphine. And we use birth weight as the dosing itself, and we do not cardiorespiratory monitor for the first dose. If the baby is treated with a second dose or more of morphine following a full team huddle with the families, the babies will be transferred to our special care nursery, and they'll actually continue to get PRN doses until they hit a threshold of receiving 4 PRN doses in a 24-hour period. Once they hit that threshold, they are placed on scheduled morphine doses like we've always done in the past. So that's really the only change we made, is moving to PRN doses. So initial doses in the nursery, a second dose, they came to the special care nursery and started getting monitored. And then subsequent doses were given PRN only once they hit greater than 4 doses in a 24-hour period, they would start on scheduled Q3 dosing of morphine. And we're a morphine unit, so whether you use morphine or methadone, I don't think there's a huge difference between the two, at least on initiation. Next slide. All right, so what are our results? So this is actually data through November of this year at Maine Medical Center. And so as you can see in the left-hand side of our P chart, our baseline rate was about 35%, and now it's about 8% treated. So of the pharmacologically, of the opioid-exposed newborns who are greater than or equal to 35 weeks gestation, we are now pharmacologically treating about 8% of the babies. So we've seen a 3/4 reduction in pharm treatment. So our baseline numbers were not that high to begin with. So we're already treating at a lower rate is what you see historically and comparatively to other facilities, and certainly what's published in the literature. And what we found was Eat Sleep Console was nothing short of transformational in reducing our pharmacologic treatment rates. Next slide. So clearly this impacted our length of stay for any exposed babies that were greater than or equal to 35 weeks. We saw a 20% reduction, as you can see on the run chart here, and it's been pretty our data has been pretty stable since the initiation rollout in April of 2018. Next slide. So one of the questions came up is, if we were monitoring the babies and not necessarily starting pharmacologic therapy, would this push up our length of stay for the babies who were never treated pharmacologically? So these are non-pharmacologically treated infants, and you can see here in almost 4 years, our length of stay hasn't changed at all. And certainly after the Eat Sleep Console rollout, there was no significant change at all. Next slide. So this, again, it was a really important piece. And so this is what happened when we went to PRN doses of morphine. How did that affect the babies? So on the left-hand side, you can see these are consecutive patients. I believe there are about 92 consecutive patients here. On the left-hand side, as you can see, that is when we were following strict scheduled morphine doses. And the baseline incidence, the baseline number of doses of morphine, I believe, is about 116 doses per patient when they were on scheduled morphine. Since we changed to Eat Sleep Console, the average number of doses dropped down to 26. So there was about an 80% reduction in the number of doses of morphine per patient. And that's on top of a 75% reduction in the percent of babies even started pharmacologic treatment at our facility. So this was really two big pieces. So we were treating a significantly less number of babies pharmacologically, and of those babies who were pharmacologically treated, they were receiving a significant lower number of doses of morphine. Next slide. All right. So one of the things, I know the average was 26, but if you look at the median of the 13 babies that were pharmacologically treated since we started Eat Sleep Console, the median number of doses, as you can see, was 5. About 40% of babies received either 1 or 2 doses of morphine, and then you can see all the other numbers of doses for this other babies that were pharmacologically treated. And we had one baby that received 119 doses. It seemed like a lot, but when we went back and looked at our old data, the average number of morphine doses was 116 per patient. So our one huge outlier would have been average 2 years ago. Next slide. Question comes up about what about emergency room visits or readmissions within 30 days. So we track this very closely. Up through the first year of our project, we saw essentially no difference in ER visits or readmissions within 30 days of discharge. They both were incredibly stable at close to 9%. Next slide. So we looked even closer at ICD-10 codes. So what were the codes that babies were readmitted for? Next slide. And so as you can see, this piece of the pie, which represents about 1/3 of the codes, were for reflux, fussiness, myoclonus, diaper dermatitis, and failure to thrive. So a lot of this is overlaps with normal newborn care. So it's unclear, we're not seeing an increase in ER visits or readmissions. And this exploding piece of the pie is some of the more common things, again, that overlap with infants in the community. So I don't think we're seeing any difference in readmissions or ER visits. Cost of care. So this was something that was important, certainly, to our financial partners in the hospital. If you could just center on the net income piece. So what we found was if a baby was non-pharmacologically cared for in our facility, we lost $1,400 per patient per stay. If a baby was pharmacologically treated at our facility, we lost $18,000 per patient per stay. So very easily, doing the math, seeing that if we can move more babies from the farm-treated bucket into the non-farm-treated bucket, there would be pretty substantial cost savings in our facility, and our direct cost savings approach that $450,000 with a total cost savings of almost $900,000 just in 2019 alone. Next slide. So our staff survey, one more slide. Yeah, so this is a staff survey looking at pre-Eat Sleep Console in red versus post-Eat Sleep Console implementation in blue. And so basically what we found was people felt more confident. As you can see, the blue numbers, the blue lines are more to the outside, reflecting higher scoring numbers on the surveys, with the exception of question 4, which asked how difficult it was it to determine a Finnegan or an Eat Sleep Console score each assessment. And on this score, post-ESC, people felt it was actually easier to assess babies with withdrawal using the Eat Sleep Console care tool versus the Finnegan. So this really kind of let us know that we were doing it right with our staff and we were doing well by our staff. Next slide. More importantly, what about our families? So again, we didn't have a ton of survey responses back. I believe this was 18 or 19 surveys. But the long and short of it was our families felt incredibly supported. They felt like they were really involved in the care of the babies. They felt like they were prepared for discharge. And a lot of people talked about how educated they were coming into the hospital. So clearly our partners on the prenatal side were doing a wonderful job discussing this with the families before they came into our facility. Next slide. Again, I've been very fortunate to have sit-down interviews with families who've been through both Finnegan and Eat Sleep Console. And I think one of the stories one mom told me, she had a previous child who was scored with the Finnegan scoring system, needed pharmacologic treatment, was in the hospital for 2.5 weeks. When she came in with her second child, she was told about Eat Sleep Console, and she told me she was very leery of it and didn't think it was going to make a difference. She told me about the dread she felt when every time a nurse walked in the room when they were doing Finnegan scoring. She was worried about one nurse was a harder scorer than the other. One nurse was going to score the baby for sneezing where the previous nurse was not. Or one nurse was going to score higher for tremors. I don't think I ever really appreciated the stress that the families felt every time someone came in. I think I remember that stress waiting for a test score to come back in college or med school. But these families felt it every single interaction. And when you talk to them after they'd been through Eat Sleep Console, it seems like that stress went away. The families did most of the scoring. They understood it very easily. They could tell the nursing staff, my baby's eating fine, my baby's sleeping well, or my baby's not necessarily consolable. It was really simple, and I think it gave the families an incredible really awareness of their babies and an incredible empowerment that they were caring for their baby, and they themselves were the medication for the baby, and I really love that message. Next slide. So what about Northern New England? So this project was launched in 2017 across Maine, Vermont, and New Hampshire. The database that I mentioned earlier that Maine Medical Center participated in now has, almost 3,000 babies in the database as of the end of December of 2019. Next slide. Again, from a regional perinatal quality collaborative standpoint, these were the PDSA cycles. So they were monthly webinars, which started in February of 17 and continue today. In fact, we have a meeting tomorrow. Again, I really, really want to thank Dartmouth for just really stepping up and doing a lot of really heavy-duty simulation-based Eat Sleep Console training sessions for partner hospitals. So 35 teams actually formally trained at Dartmouth under the simulation-based curriculum. 36 hospitals have now implemented Eat Sleep Console as far as we can tell. There's an ongoing, again, review of the data which we present monthly on our webinar calls. And then, again, having people talk about their experience with PRN dosing. That's been a little bit slower to catch on, really because the community hospitals, I think, have been a little leery about initiating PRN dosing, but it certainly has started to change in the past 6 months. Next slide. So this really quickly, I wanted to show you a quick snapshot from Maine. So this is where Maine was in 2018. There were 2 hospitals that had implemented Eat Sleep Console. Now, there were 26 birthing hospitals in Maine. There were 2 level 3 and level 4 NICUs, 2 level 2 NICUs, and 22 level 1 nurseries across the state. Next slide. 18 months later, this is what had changed. So almost all the hospitals have implemented. You can see 3 hospitals are in the process of implementing right now, and then 1 hospital has already had the education, and they're going to start down their process of implementation. So we're anticipating within 2 months that every single hospital in Maine that cares for moms and babies will have Eat, Sleep, Console implemented. Next slide. So these are data across northern New England. So again, just orient you to the slide at the bottom by month. The numbers at the bottom are how many substance-exposed babies per month across Maine, New Hampshire, and Vermont in the participating hospitals. So again, a 50% reduction in pharmacologic treatment for substance-exposed newborns during this time period from January of 16 up through October of last year. Next slide. As you can see here, again, about a 25% decrease in length of stay, again, across all of the hospitals in northern New England who are participating in substance-exposed babies greater than or equal to 35 weeks. Next slide. For pharmacologically treated infants, again, you can see there's about a 40% reduction in length of stay for the babies who are treated pharmacologically, which are less and less now across northern New England. Next slide. So this is something that is interesting, and it's different than our experience at our single hospital, that we're starting to see statistical changes in the babies who are not treated. As you can see on the run chart, we have several consecutive points above the median, which are showing, again, a statistical bump up in the length of stay. So we're starting to see a slightly higher length of stay in the babies that are not pharmacologically treated in the entire cohort across northern New England, which is very interesting. Next slide. This was fascinating. We started looking at this a couple months ago and looking at the need for a second pharmacologic agent. So whatever people started on, whether they used methadone or morphine for the primary agent, how many babies required a secondary agent? So again, either methadone or morphine is a secondary agent, or phenobarbital or clonidine. On the left-hand side of the slide, for the first 2+ years of this project, about 5% of babies were started on a second pharmacologic agent for their withdrawal. As we've really implemented Eat, Sleep, Console across the region, that has now dropped, as you can see, down to, that's 0.7%. So it's a huge reduction down in the need for second pharmacologic agent, which is really interesting to me. Next slide. And this is something we also track as breast milk use. So what % of babies receive breast milk at the time of discharge? And this is mother's own milk. And this is something, obviously, that we're going to be working on, hopefully in the next year, to really change this. So the baseline rate is pretty high to begin with in this population at about 54%. But as you can see, in the past, essentially 4 years, we have not been able to budge this needle at all. Next slide. All right, so one more slide. Again, yeah, next slide. All right, so you can keep going. Great. All right, so a couple things about final thoughts about Eat, Sleep, Console. So clearly, I really want to stress that some infants will require pharmacologic therapy for symptoms of withdrawal. It is not a failure. It definitely happens. And as you can see, both at our hospital and across our region, I think the sweet spot is going to be somewhere between like 8 and 15%. And we're starting to see that across the country in large data cohorts that about 8 to 15% is kind of where all the data is living after full rollout of Eat, Sleep, Console. So I really think that Eat, Sleep, Console will allow babies who have mild withdrawal symptoms to maybe not need pharmacologic therapy. And then the potential for PRN dosing at the peak withdrawal, you may be able to get the baby just over the hump of that really, really bad withdrawal period, and they may only need several doses. If you look at the recent study, the morphine versus methadone study from Jonathan Davis's group at Tufts, in that study, the median number of morphine doses was 90, or the median number of methadone doses was 36 doses for babies who are pharmacologically treated. With PRN dosing, you may be able to reduce that exposure down. Eat, Sleep, Console, some people use the word symptom prioritization, so really only following symptoms that are easy to recognize and almost as important that are the ones that are clinically important to the families. And I think it also really allows the medical team some structure to really provide true family-centered care for opioid-exposed newborns. I think clearly the medical establishment has not done well by women with substance use disorder and infants affected by NAS over the years. And I think some of the messaging, whether it's Eat, Sleep, Console or really any type of really family-friendly messaging, I think is incredibly important. And certainly time to really make sure we do a better job with that. Next slide. Next slide, you can keep advancing. All right, so if your team does implement Eat, Sleep, Console, I think a few things are absolutely needed. One, there has to be strict training for staff, without a doubt. There has to be support for families. There has to be a very safe transition of care to the outpatient providers. And I think if you're going to implement this on a large scale, you need to make sure that implementing this change does not affect your readmission rates or your emergency room visits. I think the last thing anyone wants is to send out a baby that's still withdrawing into a potentially unstable social situation. So I think that's really important. Opioid-exposed newborns do not necessarily need to be in intensive care units. They need intensive caring, but they don't need to be in intensive care units. And lastly, I think development of follow-up is absolutely needed, not just in the pharmacologically treated babies. That's who we really centered on a lot in the past, but we need to be giving development of follow-up to babies that are exposed to opiates in utero. I think those babies sometimes fly under the radar, and I want to make sure again, I think all of us want to make sure that those babies are not missed, and we provide the babies with the best developmental follow-up as needed. All right, next slide. So for those fans of Spinal Tap, I think Eat, Sleep, Console tells us you want to take non-pharmacologic care 2 and 11. And last slide, I know I said I wouldn't do this, but and if you hit play while we're waiting, you can watch the last play of the Super Bowl 51. All right, I think that's it, and I am available for questions.
Thank you so much, Dr. Piccirillo, for a great presentation. I'll unmute the line, so please feel free to ask questions or share how this relates to your experiences.
Alan, thank you. This is Ravi. That was really excellent.
Student life at Augusta University is highly diverse.
Okay, I'll leave it on unmute, but if you would like to ask a question, just press *6.
Hey, Alan. Sorry about that. That was really excellent. Thank you for that overview. I think it's great to see some of the outcome data you've had, and appreciate you presenting. I had a couple of questions, and I'm trying to get over my heartbreak from the video you just showed me of the Falcons. But what do you think in terms of for centers that have challenges with kind of rooming in, either capacity or capabilities for rooming in, and what they could glean from Eat, Sleep, Console, kind of the approaches when it may not be that there's an ability for the babies to stay with the moms in the rooms?
Dr. Piccirillo, *6 to unmute.
Sorry about that. Oh, thank you, Ravi. Yeah, I think the capacity piece is definitely a major issue. I think, what I've seen in hospitals is just getting creative. I think as those hospitals who have pediatric units, I think their capacity, it has decreased down with just a better care of pediatric patients with chronic illnesses and between vaccinations. And so they have capacity on pediatric units. And so people are starting to care for newborn babies and not necessarily in maternity units. So again, if there's availability in other parts of the hospital, people have just taken on that challenge and really thought through it. But in the absence of that, and I know we hit issues with census from time to time, that it definitely can be a struggle, and I know people get incredibly creative. But if we created patient days, so our patient days actually went down by about 700 with implementation of Eat, Sleep, Console last year. And so we were able to, again, get creative with our maternity unit to have the baby stay in postpartum. But you're right, but this is a huge challenge.
And do you have thoughts on kind of alternatives? And I know, sending teams to Dartmouth would be kind of great for intensive training, but, it may not be possible for a lot of centers. Do you have kind of thoughts on other alternatives that might be out there for centers to kind of become more confident with this method, but maybe short of traveling to Dartmouth or other, places for doing more intensive training?
Yeah, I think, again, I think the Dartmouth training is great. I will tell you, most of the main hospitals did not receive training at Dartmouth. Only less than half did. The others, we actually, had a train-the-trainer model where one training group went to Dartmouth and they went out across the state to do the training. Again, contacting the folks at Dartmouth, they have a really wonderful Eat, Sleep, Console care, eSleep Console Care Tool Kit. They have an implementation guide for hospitals, and I think that is a nice roadmap to follow in the absence of not being able to head over to New Hampshire to get the training. But just having, if anyone can actually, spend time in a unit that does eSleep Console and does it well, it really transforms your thinking, and it did to me. Having had a lot of experience with neonatal syndrome over the past 20 years, seeing eSleep Console in action was really, again, nothing short of transformational.
Very well, thank you. That's been really helpful. And there's been a lot of interest in eSleep Console, but I think kind of making that first dive into it, I think, is always a challenge for where it may be very new for all the centers and their staff.
Yeah, definitely.
Hello, this is Jessica Dago. I have a question about when you mentioned developmental follow-up. Is there a certain tool that you think the outpatient providers should be using just for consistency? And also, is there any interest in looking up outcomes long-term, too, from the eSleep Console with regards to the development versus those who receive pharmacological therapy?
Yeah, that's a wonderful question. I don't know of any specific developmental tool per se. I'm definitely not a developmental or pediatrician. But as for the question, are people looking at this? And the short version is yes. There's a very large study just getting started now, I believe, in Burlington, Vermont, with several partners around the country, specifically looking at developmental follow-up of opioid-exposed newborns. And they're going to be able to separate the babies based upon if the babies are treated with eSleep Console versus the traditional Finnegan scoring system, looking at both pharmacologically treated babies and babies that were never pharmacologically treated. So I'm really hoping, again, in a few years, we'll be able to see some data from that study and elucidate some of these concerns people have. And I think it'll be wonderful.
Yeah, and which group is that again? You said is doing that?
Burlington, Vermont, at University of Vermont.
Okay. Yeah, that would be interesting because that's one of the questions that I get from families too, is just trying to understand the potential impact, that it would have on their children. And I also thought it was interesting what you said too about even just looking out for those that were exposed but may not have necessarily had to stay in the hospital long. I think sometimes it's interesting, like the culture, like, okay, this mom had a hip surgery, so she was taking a few more pain pills than some, and then just kind of seeing like that spectrum, like how much is too much, and all of that too. So that's very interesting that you mentioned that, like, and some babies may have more or less tolerance as well,
Absolutely. And the other person I would point in the direction is Barry Lester. Barry's a PhD developmentalist out of Brown University in Providence, Rhode Island, and Barry's one of the world authorities on opioid-exposed newborns and about their long-term developmental issues. So definitely look into some of his writings.
And what's his name again? If I can write it down.
Barry Lester, Lester.
Okay. All right. Awesome. Well, thank you so much.
You're very welcome.
Are there any other questions for Dr. Piccirillo? Okay, Dr. Patel, I'm looking at the time. Maybe in the interest of time, would you like to give a kind of a high-level overview of the QI project template?
Sure.
And we can defer the in-depth till next month?
Yeah, I think that sounds fine. So hello, everyone. And, we've been talking on kind of our calls about having some of the centers sharing some of the exciting work you're doing. And we wanted to tie it into some of the work we've been doing on kind of the QI technical calls in terms of talking about our smart aims, key driver diagrams, run charts. And to help facilitate centers presenting, we've tried to create a template that can be helpful to you and as a way for you to be able to present to all of us on future webinars. And so Laura and Katie will be sending out just a draft template that kind of highlights in a very high level view within 10 slides to really share the kind of key aspects of your project. Picture of your team, what your smart aims are, whether they're process aims or outcome aims or both, and balancing and patient family-centered measures that you may have. And then we really want to see what your key driver diagrams are. We've talked a lot about this. We've been working off of our kind of statewide collaborative key driver diagram, and we also want to see what you're using specific to your own smart aims. And I think this is the one we've been kind of using to structure our initiative. And then as you progress, we're past kind of the 6-month mark, sharing some of the descriptions of your PDSA cycles, and we've kind of shared the PDSA worksheets. We'd love for you to use that to kind of describe your PDSA cycles that you've been doing. And as time goes on, working on run charts, and there's an Excel template, and if some of you need help with this, please reach out to Laura or myself, and we can kind of help you work with kind of generating run charts. But this is a great way to depict your hospital-specific data that we're sending with you, and this is just one example of data that we just sent out to that you've received in the last quarter about your kind of length of stay from our state. And finally, some of the barriers and kind of learnings you've had along the way, and how you've overcome some of the barriers. And I think this will be helpful as we work and learn from each other and other centers in terms of what we're doing. And so we hope to use this on future webinars to hear what you're doing and to kind of share your experiences. And this is just a template. You can feel free to adjust that. And we'd love to kind of learn from all of you, and hope over the next year we're going to have be kind of asking you and asking for volunteers to share some of your experiences. And
wonderful.
That's it,
thank you, Dr. Patel. Thank you, Dr. Piccirillo, for a wonderful presentation. We do have a couple of reminders for you. Our next call will be February 11th, and we'll focus on NAS scoring. Also, please save the date for our annual meeting. It'll be in Atlanta, April 23rd and 24th. And finally, look for more information to come, but DPH will be switching from our free conference call platform to Microsoft Teams. So we'll use Teams for our webinars. We'll be able to record and post within the platform. So we're just simplifying and improving communication and ease of use. So be on the lookout for more information via email. So I just want to thank you all again for your participation today and in the collaborative. If you need anything, as always, you can reach out to Katie Kopp or myself, Laura Lane, in the Office of Women's Health. So if there aren't any final questions or comments, we'll go ahead and adjourn for today. Okay, thank you everyone very much. Have a great rest of your week.